Health and Human Services Committee meeting. We have one of our committee members is not going to be in attendance today, Amanda, and we have one committee member, Susan, on Zoom. And by our recently adopted rules, we do have enough for a quorum, so the quorum has to be here, and they are. So we're going to get started. For changes to the agenda, I just wanted to add in, we have Sue Ellen Stewart here, Executive Director of the Visiting Nurse Service, and she's going to be doing a little presentation on an innovation grant. I don't know if it's going to be like coupled with yours or separate, whatever it is, it's all good. And any other changes to the agenda that anyone knows of? No? Okay, very good. I don't see any public here. We didn't receive any virtually. Very good, thank you. For Chair's report, I just want to mention one thing. I had heard some people talking about something they said 11:15, and they started going on and on about 11:15. I didn't know what they were talking about. And they said, oh, this is a thing that a lot of us in the human services field are paying attention to, and there's a seminar or a workshop coming up about it, and so you should go. So I attended this webinar last week, and I'm just going to tell you the tiny bit that I learned because I really didn't understand everything they were saying. They kind of started in the middle. So Medicaid 1115 waiver, there's something that's in existence already, but they're going to modify it. New York State is going to modify it probably sometime this fall. They're still working on the details. And it's going to affect the way Medicaid services are delivered. It's going to try to take what they're calling social care services into account. Some of us may have heard the term social determinants of health in the last 5 years or so. It started getting used a lot. Apparently this is what the term has now graduated into, social care services. And it has to do with integrating health equity into Medicaid, improving Medicaid outcomes, screening Medicaid participants for needs and meeting those needs, whatever they might be, including things that are non-traditionally health and medical needs. That was the little bit that I learned. I just wanted to put it on your radars, the term 1115. Maybe we'll all be hearing about it more over the next 6 months or something like that. So that's my little report. And if there's nothing else, we are going to dive into our first presentation. We have Dr. Marty Sloan here, CEO of Cayuga Health System. Dr. Sloan came to us earlier this year, I think maybe it was March or so, and it was a really good meeting. It was one of my favorite committee meetings ever, and he said he'd be happy to come back anytime, so I took him up on that offer. We've asked him a couple of topics in particular, but it's also whatever he would like to talk about, whatever we would like to ask about. So Dr. Sloan, you're on.
Super. Thank you, Dan, for having me. And I was the person responsible for inviting Sue Ellen Stewart with me. We're a team of sorts. I definitely want to start off the meeting by announcing that the Department of Health has approved VNS, at least the first of two halves of VNS, affiliating with Cayuga Health officially. So we're waiting to close on that, but among other things, I'm hugely excited for the possibility of integrating home nursing as a capability within Cayuga Health and to assist VNS in growing. And frankly, we're looking to depend on VNS to implement our strategy of providing more integrated care. And I do want to state for the record, if this is recorded anywhere, that Sue Ellen has been an innovative and energetic partner, and what she's going to talk about in a little bit, I think, proves that. So we're very excited about that. I think the point that you wanted me to touch on was mental health services and our existing capacity and our intentions, and I will. I wanted to frame that with the realization that Cayuga Health is more and more framing itself as an integrated delivery system, where we have a collection of organizations that are working together to provide a continuum of care that different organizations may have the licensure to deliver or competencies or staff, but that in the aggregate and with coordination, we're able to provide more seamless care across the continuum of healthcare services, to include what you mentioned before. What the 1115 waiver is looking for is the inclusion of human services in the mix, not only healthcare services, but connected human services. And 1115 is something that we've been following extremely closely, and we're looking forward to playing a central role in that. And our development as an integrated delivery system is equipping us to do so. And I give a lot of credit to Rob Lawless and the Cayuga Health Partners Clinically Integrated Network, because they have many people who are engaged in identifying, cultivating, and forming the network of actors that work together. As just one example, we have an incredibly close partnership with Food Net Meals on Wheels, whereby we intend to offer congregate dining at the Sears space in the mall when we finally build that out. We are hoping and really succeeding in integrating the travel plans of VNS traveling nurses, but also food delivery workers, and how can they work together to serve what largely is the same clientele, or often is the same clientele. So that's a little bit about Cayuga Health broadly, and at another time I can define all of the components of how we are an integrated delivery system and IDS, but I think you wanted me to focus on the mental health piece. So I'll start by the outpatient environment. We began outpatient mental health services connected with our primary care services a few years ago, and it's an integrated behavioral health model. A psychiatrist named Laura Sideri, who was formerly at Cornell, came and before Cornell, she was a military psychiatrist, where she worked within a very reputable and functional integrated behavioral health program. And she's effectively built that for us. Right now we have 10 mental health care providers that are embedded, sometimes physically, but always physically or virtually, with our primary care locations, and we're growing that service throughout Cayuga Health System. So at the present time, we have 4 primary care locations that have mental health professionals embedded and integrated with the primary care doctors. And there's 2 new locations coming online. The first is our rheumatology practice, and without getting into details, there are a number of rheumatologic diagnoses that would be nicely augmented by the presence of a mental health specialist, along with the physical medicine aspects of those conditions, and then a 5th PCP site within the next 6 to 8 months. So good reach. The idea, the premise of the integrated behavioral health program is that there are not, and there will likely not be, enough mental health providers in the system writ large to have them completely separable. Plus, there's merits of integration. So the presence of the mental health specialists augments and educates the PCPs from taking on a large amount of simple level mental health care. And that really force multiplies our workforce. So that's at the integrated behavioral health level. At the present time, we do not have specialty outpatient mental care, so we're not offering standalone referral for complicated outpatient care. For that, we refer to Tompkins County Whole Health, along with an array of other healthcare providers, but that is still under the level of outpatient, elective, non-emergent, non-crisis basis mental health care. We skip a whole level, and I would say the next level exists within CARS, Cayuga Addiction Recovery Services, which, like VNS, is a member of Cayuga Health System. They offer combined substance use disorder and mental health treatment on an outpatient basis. They have a number of mental health providers, but the purpose is really, or I would say the prime mission is the substance use disorder population, although they recognize they those patients are dually affected by substance use disorder and mental health conditions in ways that are not capable of being dissected so easily. And then we jump to the hospital level, and I'm putting an asterisk in my comments between the outpatient level, substance use level, and hospital level, which is where I'm going to come back to about the crisis stabilization concept. At the hospital, we have an emergency room location. There's a single room and then 4 rooms adjacent to the emergency room where we handle acute patients coming into the hospital that have some suspicion of needing hospital-level care. Sometimes it's quickly evident that these individuals don't meet criteria for coming into the hospital. That is a regulated setting from many perspectives, one of which is the payer perspective that would deny care for crisis level but not fully inpatient level. There's also a limitation of the number of beds for our inpatient unit. So in terms of numbers, we have 20 adult beds and 6 adolescent beds. There are the ability to take 2 of the adult beds and use them for adolescent and vice versa. So there's a little bit of flexibility within the cap of 26 patients in the hospital. That is a very regulated location by the Office of Mental Health and the Department of Health, Joint Commission, and other agencies to whom we answer for our practices and our capacity. If there were numbers in addition to that, they would back up in the emergency room, the 1+4 beds that we talked about, or into the emergency room proper, which consists of a separate 25 spaces, not then counting the waiting room or other areas that we can open up. So that's the Cayuga Health capacity for mental health, and I want to just focus on what our intentions are for the Crisis Stabilization Center. In keeping with the concept of a continuum of care, we recognize that there is a huge jump between outpatient office-based mental health or outpatient facility mental health, such as what CARS may offer its residents, or what the hospital on the inpatient side offers, and what people experience in so-called crisis. I'm not fully qualified to tease apart the definition between inpatient crisis and outpatient mental health, but there's a glaring gap evidenced by the number of ED mental health related visits that happen each month, which measure in the many dozens. And sometimes these cases are the saddest cases because there's truly nowhere to send these patients emergently. It alters hospital operations. That's not the best place for those patients. It's not the best place for the patients that are receiving care next to them because of the unique needs that they have. It's also straining what is arguably the most expensive site of care in our health system. So for those reasons, Cayuga Health is committing to a crisis stabilization level of care or equivalent. What we're doing now is we're having ongoing conversations with the Office of Mental Health, both at the state and regional level, in conjunction with Tompkins County Whole Health, about the model that is available to us and dually works for what the community needs. At the end of the day, I want to reiterate our organization's commitment and our board's commitment to being involved at that level of care that we're not involved in right now. And so while I would love to tell you the exact plans, those are in the works. I will share that there are other organizations, regulated mental health and substance use disorder providers in the region that we are talking about that I believe will only add options and different dimensions to how we will ultimately solve it. I'm not prepared, based on the stage of maturity of those conversations, to go into any detail, but it would involve collaboration, affiliation, and cooperative endeavoring together. So I'll end my comments on mental health there, and I do want to say a couple of words about some new services and practices that we are committing to that this body should be aware of. Any questions? Or I can keep going.
Any questions? Randy? Yeah.
Only took 5 minutes, but it's like, wow. You know.
I feel the same way.
So you mentioned that in-house for mental health for kids, you have up to 6 beds. Is that how?
At the inpatient level, at the adolescent level, yes. Yes.
Is that capacity working, or?
It is insufficient in the region. Those 6 beds are, the region needs more capacity than what we have to offer. There's also complexity of care and specific diagnosis within that range that may or may not make those beds appropriate for an individual person. So I would say that in general, there is an insufficient number of inpatient beds. We are very fortunate to have those adolescent beds. But sometimes, because of complexity of the case, we do struggle to discharge patients from our emergency room who don't qualify for our specific services because of one reason or another on the technical level. At the end of the day, there's a board-certified psychiatrist and mental health team that make the decision to admit based on a variety of factors. So I would say it's a blessing that we have those beds. I wish we had more, and they are not everything that the community needs, but it is, relatively speaking, for this size community, a blessing.
So they may get sent to another facility if that's,
Yes.
that what happens? Okay.
Yes.
Are there somebody keeping data on that type of thing? Or?
Yes. We have detailed data. I don't have the data here. I
No,
can
it's
come
okay.
back.
This is-
But yes, that is something that is reportable to the state. But we keep all sorts of data on all sorts of cases in terms of length of stay in our institutions, which cases are ultimately denied by insurance companies, which cases there's barriers to discharge. We have a lot of data on those cases.
I was speaking to a first responder group in Enfield, and they were relaying to me that sometimes they get called out for things that aren't really emergencies, meaning, somebody's got a bad tooth abscess or something to that effect. Do you track that type of data too? I mean, so are you getting people in the emergency room that maybe if there was a little bit of planning?
Yes,
that would.
there's a severity system, a 1 through 5 scoring system, where depending on the number of resources needed, and that's a defined term, the case can be described as one that would have been able to be handled by a primary care provider or a different level of care, and so we track that. And indeed, we are burdened by cases that don't need the emergency level of care because of a lot of reasons. One of which is the difficulty of staffing outpatient practices. And so you might look to primary care, availability of urgent care, and the emergency room being an overused safety net for that other level of care not working as properly as it should because of, among other things, staffing difficulties or lack of providers or one of another reason.
Yeah, that's not a surprise, I guess. I know my mom's been guilty of calling 911 more than she should have. Which she could have just called me. But she's 91 and,
Hindsight's 20/20.
Yeah, exactly. That's all the questions I have right now.
Other questions? I just wanted to ask a little more. So you talking about the 20 adult beds and the 6 adolescent beds, that's mental health care inpatient?
That's right, inpatient level. That is, you might say, regulated and watched and judged on whether or not those patients meet very specific criteria to be in the hospital. And people who don't meet that level can still have serious problems, but they're not at the level that justifies inpatient level of care. And that's as much a payer side definition as anything else.
How long might someone stay in those beds?
We've had patients for weeks to months in those beds, and we've had people as few as a couple of days.
And this would be a generalization. Are they full all the time, or more or less?
No, they're approaching full all the time, but in the transition period, there's departures, there's discharges of patients, and then before another case meets criteria, there may be a decrease in census. So I would say that unit is well utilized, but it's not always completely full.
Mostly full all the time.
Mostly full all the time.
Those were all my questions. Travis.
Often out here in different settings, IPD and even the sheriff's department, I forgot what the code word is, but when they bring somebody up to the hospital because they're having some sort of mental health issue, and probably more often than not, they know that's not the best place, but it's the only place. And then the problem they run into is people can sign themselves out and they're right back out, and some folks have come up there 2 or 3 times in the evening. Would the stabilization unit help?
Yes, one of the purposes, that's a great question. One of the purposes of the stabilization center would be a way to handle and serve the incarcerated population, but also cooperate with law enforcement. There are certainly challenges involved in terms of the protocol of ambulance being directed to the hospital. There's EMTALA laws, for instance, that don't allow an ambulance crew to make a determination that a different level of care other than emergency is needed. But my understanding is there's ways around that with medical direction, so that if there's an integrated psychiatry and ED, a cooperative psychiatry and ED team, that there is a way to have emergencies that are clearly mental health in nature end up at the crisis center. But that all of the details are not worked out. But the idea is to unburden the emergency room, and once you bring someone to the emergency room, there's a fixed cost of an emergency stabilization exam or medical stabilization exam that's required by federal law, EMTALA. And so if there's a way to do what I was saying, that would benefit all parties. And again, I emphasize the emergency room is not the place for these patients necessarily. That's not where they're best served. And so if there was inpatient mental health level of care needed, there would be transportability from the crisis stabilization center to the inpatient unit, and we would be facilitating that patient channel as well. So all of this is in the programmatic process of being defined. But I do want to let everyone know where we're at and be clear. We haven't decided on an exact model. We've applied to an intensive crisis stabilization model and separately a supportive level model. Neither of those applications were successful with the state. There is now a third model called CPEP, Comprehensive Psychiatric Evaluation Program, which is a standalone psychiatric emergency room. That's got challenges based on the nature of existing care infrastructure in our community. Again, I emphasize that Mr. Krupa and the whole health team is involved in those conversations, so these are not things that we're having unilaterally, and we're committed to, again, providing that intermediate level of care between inpatient and outpatient elective, if you will, or non-emergent for this community.
So I met with some school officials and therapists and counselors, and they were asking about a particular issue where a child ended up in the hospital, and they had some mental problems, and they didn't really understand. So that happened, and the child definitely needed some help. But 3 or 4 days later, the child came back to school, and they didn't have any communication. And I know there's HIPAA laws and all those kinds of things, and they didn't know how to deal with that situation. So, and I know that you've worked with Whole Health on warm handoffs. I think that's what they call it. And also the county just awarded $700,000 to 8 organizations related to opioid settlement funds. So maybe some of that will help a little bit. That's going to be voted on tomorrow night. And I know there was other funds that talked about that. So what are your thoughts on that?
My thoughts is that communication sometimes can be a challenge with patient privacy and related restrictions. I think that in the scenario you mentioned, and I'm taking this, at first glance and at face value, if individuals had a right to know that there was a hospitalization, if presuming that's the case, I think it's reasonable to further ask what, if anything, we need to know as the school health division to facilitate the situation, being open to the idea that the answer may be it's not appropriate to know anything at this point. But the question is reasonable. Once if you presumably knew the first part, it's reasonable to ask what role they could have or should have in the second part. People do have the ability to compartmentalize their care under New York state law, so I can't get around that, but we should be able to exchange information with releases. And I know that that's a particularly complicated situation because there's, depending on what age, you can get into child being able to consent and not parents and vice versa, depending on the age of the individual involved. And so, yeah, I think between 10 and 18, children can make their own consent decisions for a number of health issues without their parent. And so I think that's complicated, and I don't want to bury the lead in a complicated example. Is that, I mean, I think our mission is to be more involved in a certain level of care that is a gap in this community. That's the main part. And then once that level is filled in, we should adopt best practices within the constraints of laws and regulations on communicating between the different parties that are involved. Those are my thoughts.
I wanted to ask a little more about the Crisis Stabilization Center. So you mentioned that there were two different levels or types that you had applied for, and so far no luck from the state, but that there's a third type?
Well, I wouldn't call those, the third was not a crisis stabilization center. It's more intense. It's a full-blown psychiatric emergency room. And sometimes you need to avail yourself, if you're an organization, of the programs that the state is encouraging based on funding and licensure. We're not sure. The third one, but just to be clear, is not crisis stabilization. It's a level above that.
And is your organization contemplating pursuing that? Or? Okay.
Yes, we are. There's, like everything else, I'll use the word, a dizzying amount of regulations and nuances, and we're working through what would work for the community and what is impossible based on physical infrastructure, the location of existing capacity, partnering organizations, capacities, things like that.
Other questions before we continue with the presentation? All right.
I will round up. Thank you for the questions. I want Sue Ellen to get a chance to speak, but I do want to say that amidst everything we're talking about, we are continuing to evolve as a health system. So in the past year, we had a number of new services and also acquisitions to the health system from existing community organizations that benefited from or needed in some way to join Cayuga Health. So just to name a few, we just opened a new urology practice with the blessing of our outpatient urology practice. That's a private practice. CMA plastic surgery was opened. 2 family practices that, for different reasons, I think, and this is not to impugn those institutions, but I think primary care on the private side is jeopardized just based on modern medical economics. So Family Medicine Associates of Ithaca and Dryden Family Practice both joined Cayuga Health successfully. We are providing student health services, formerly Hammond Health, but we're the behind-the-scenes practice for the care that's being rendered on Ithaca's campus. And those are a few of the examples of new organizations or new service lines. In each of the existing service lines, they are growing or evolving in some way. So for instance, we're growing from a neurology point of view. I think we now have 7 neurologists in the community. We are drawing patients from as far away as Pennsylvania, north of Syracuse, Utica, I mean, very large geography. We had the addition of a world-class cancer specialist from Memorial Sloan Kettering who's got a worldwide patient drawing, including international patients. And so I just wanted to report back that Cayuga Health continues to evolve in organic and inorganic ways. But to transition to Sue Ellen, one of the parts that I'm most excited is when we add capabilities that we didn't have. And one of the capabilities, again, we didn't have, even though we have hundreds of nurses in our organization, none of them have the ability to go into the home and render home care, which we believe is the future, without the licensure and expertise that VNS brings to the table. So I am deeply, I'm excited. I am deeply gratified that VNS is joining Cayuga Health based on what we're going to be able to do together. And I wanted Sue Ellen to come and just say a couple of words and provide information, but one of the exciting parts that I believe, I just want to put my stamp on one thing, is that I know EMS in the county is strained, and even you yourself said that there are cases where people who need a fundamentally different level of care are accessing and straining the EMS system. I believe that an integrated VNS EMS solution will reduce that burden at the demand level and allow EMS to do what it's really intended and necessary to provide. So I am hoping that the county sees the wisdom financially and from a service perspective to include VNS in the plans to address the EMS problem when you get around to voting on exactly what to do. And so with that, I wanted to allow Sue Ellen time to speak.
Thank you very much. What a lead-in. Now, if I can just pull up the presentation. There we go. We have a tremendous opportunity for an innovation grant, and the innovation grant is between home care and hospitals and EMS and also physicians. And the grant is sponsored by the Home Care Association of New York, so all the home care agencies in the state, most all of them belong to the Home Care Association, and Iroquois is a hospital association. They, together with IPRO, which is a quality organization, have gone together to work with Mother Cabrini for funding. And Mother Cabrini is a foundation that's in New York. It was formed with the sale of Fidelis. So the funding for the project that I'm going to present is coming from Mother Cabrini, which we're very grateful for. So this is a partnership here locally between VNS, Keuka Health Systems, Keuka Health Partners, which is the physicians, and then the community EMS providers. We've got 21 members that are over across, different organizations that are on the planning team for the project. We're doing the planning and implementation for the project between now and January 1st, and we hope to launch the project in January. So there are already 3 other counties in the state that have launched a project like this, one in the North Country in Watertown, one in Binghamton in the Southern Tier, and one in the Hudson Valley. And they wanted to expand this innovation model to 2 additional areas in the state. We were very fortunate that we were chosen as one of those. And then the other one is in St. Lawrence County. So the grant means probably $250,000 to $300,000 for the area. So the project is for admitted VNS patients only. So it's not open for the public at this point. And the reason for that is, on the next slide, this will provide control for the project. We already know the patients, and so we will be able to do control of the project and do triage and make sure patients are appropriate for the model. And if we can get this stabilized, we do want to open it up for everybody in the community, but it'll start out with just admitted VNS patients. So to show you a little bit about VNS patients, this is the patients that were admitted to the hospital so far this year. There were 187 hospitalized. It's an average of 6 per week. The biggest reason for them being hospitalized was some kind of respiratory issue, followed by some type of infection, and then the third reason are falls. Then the next slide is to show you our ED utilization. And again, this is just admitted VNS patients. We had 157 ED visits so far this year. And that's an average of about 5 visits a week. The picture is a little bit different. The biggest reason that they went to the ED was some kind of urinary issue, a UTI, a urinary tract infection, or a Foley, a problem with a Foley. The second reason is infection, and the third reason is, again, falls come into play a lot with both hospitalization and ED patients. This is a map showing our VNS patients across the county. So you can see that the majority of our patients are right in the Ithaca area. There are a lot in Lansing, a lot in Dryden, and a lot in Trumansburg. Those are the largest regions. We serve about 250 patients. Our census is about 250 patients every day, and we see over 3,000 patients in a year. So when we look at the savings with a project like this, what we're hoping is after we launch the project that we can reduce hospitalization and ED utilization by 50%. So if we take those numbers and you know, with the average cost of a hospitalization being $15,000, we would have a savings of about $2 million if we can reduce it by 156 admissions a year. And for the ED visits, using a dollar amount of $692, we would save about $90,000 a year. Well, this slide doesn't come through very well. We're also doing this project in Schuyler County, and Schuyler's a much smaller area, and I don't have as good of data in Schuyler because we haven't been the home care agency that's been servicing the county. But if I take some of our numbers from Tompkins and apply them to Schuyler, our projection would be to reduce the hospital admissions by 19 and the ED visits by 18 and a half. So this is an overview of the process of the model. So we would have a patient that has a change of condition, whatever that is. Our nurse could identify it, the patient could identify it themselves, and that our VNS nurse would triage the patient, you know, determine where they're at, if they would be appropriate for this model, or whether or not they have to be transported to the ED or the hospital. We would set up a virtual care appointment for the patient to be seen at home. We would also call and ask for an EMS provider. It would have to be a paramedic to go into the home to see the patient at the same time that they have the virtual care appointment. And we would hope to stabilize the patient in the home rather than having to transport them. It's not appropriate for everybody, but we feel as though there are many of our patients that could be stabilized at home and prevent the transport. We would notify the primary care physician that we're doing the intervention, that their patient is being seen in the home, and then our nurse would go in the following day and follow up on any change of orders. So one of the keys to this project is what we call a zone tool. And there are zone tools that have been developed by Medicare and Medicaid, and they're a standard tool, and it uses a red light, green light, yellow light concept where you can determine the status of the patient's condition. So we're trying to target the patients that are in the yellow zone, which is a cautionary zone. Red zone, if they are critical, they need to be transported, but we're trying to target the patients that are in the yellow zone to see if we could stabilize them in the home with a MD appointment and the EMS provider going out to the home. So this provides a common language for our community. So we're going to be training our patients on the concept. We're training our staff. We're also going to be training the MD offices and the EMS providers. So everybody will be using the same language. So we could call like the MDS provider and say, we have a patient with diabetes, they're in the yellow zone, and this is what's going on. We feel that they could benefit by a visit at home and stabilize them. So it kind of gives everybody that common language. Just some community benefits. This concept supports the age-friendly community by bringing care into the home. It takes stress off the emergency providers and emergency system. This is a great concept where you could use fly cars. An ambulance would not have to be used. The paramedic could go out with a fly car. Even they could go out in their own car, so it takes some stress off the system. It creates, again, the common language for the community to use and a tool for better patient teaching. And then it promotes early intervention and patient understanding by using the zone tool and helping the patients understand, their condition, and also that they have an option where they could get care without having to go to the ED. We think they'll get care sooner. And that is going to, prevent the ED and the hospitalization. And it builds a foundation for other projects, for remote patient monitoring, for a hospital at home, but it's really the beginning of all of us working together and forming a foundation for other projects to, in the future. And then it also supports the expectation of payers. They're expecting value-based payment, and expecting us to be all working together to see what we can do to take the stress and the cost out of the system. So again, we're hoping to launch this in January. You know, there are a lot of people working on it, and it's really exciting. A lot of support for the project with the physicians and the EMS providers at the Keuka Health Systems, and we're really excited to have the opportunity. Do you have anybody have questions?
Questions for Sue Ellen? Randy?
Some of this is new to me, so that's why I know I was always aware of visiting nurse, but I never really understood all the things that it did. You mentioned, so what is the county connection? So how does the county work with visiting nurse, or they don't? It's just between Keuka Medical and doctors, and do they call 911? Is that the only connection? How does the connection? How do you communicate with the county? Or how does the
We have a strong connection with Office for Aging, which is with the county. If we launch a project like this, it's going to be important that everybody knows that we're, doing it, and that it's something that's going to benefit, our aging population. So even, the fly car concept, I think there is some possibility of funding for fly cars, which would, make them more available to help support a project like this.
You know that we have 2 home health aides part-timer through Office of Aging now, I think? Is that correct?
1 or 2, I'm not sure at the moment.
So if you work through the Office of Aging, do you know what clients they're working with, or so it's no overlapping, or how does that work?
Well, no, not necessarily, but they would, if it would be important for them to know for any patient that's a VNS patient that we would have this option now. But again, we hope to expand it for the community, later on. Another thing is we're working on an interface between our VNS system and the physicians' offices in the community. So they're going to have much better information about our patients, and we're going to be able to communicate much faster with them, and that's going to be a real key to support this project.
Yeah, we have an aging population, and it's heading that direction quickly, I think. In-home care makes a lot of sense. I know with my elder relatives, most of who have passed away, the only reason they were moved out was because they couldn't get in-home care, right? So, because it's a challenge. You talked about virtual a little bit. What do you think we're headed with virtual care? Maybe it's a question for both of you.
What do I think the value?
So it's here where you have doctors on demand for Dr. Phil, for example. So that type of service is happening, and maybe more than I know. I was just curious.
Yes, there's the virtual care center now at Keuka Medical Center is available until 7 o'clock at night for people to have a virtual care appointment.
It's being demanded. It's an easy way to reach people who have transportation barriers. It's a way it's a way for physicians and other providers to collaborate in the care of patients. And so I think that we're at the beginning of this. COVID, one of the good things that came out of COVID was the acceleration of the acceptance of telemedicine and related applications. But I would say we need to rapidly evolve in this community and our adjacent communities about the full suite of technologies augmenting and leveraging the care that the traditional system is able to provide. So I would say Cayuga Health is committed to that journey and development. I do want to go back, if you don't mind, to something you asked about how does this connect with the county. I want to make a very fine point. I understand that the problems that we're facing by having siloed services have become what I understand to be a county-recognized problem about EMS response times. And I'm aware that the county is entertaining solutions that would involve resources to solve it. And the kind of solution that Sue Ellen Stewart put on the table with the Mother Cabrini grant, and more importantly than the grant is how we would be operating together is a constructive, holistic solution to the problem that the county is now dealing with, even though the county didn't create the problem. So at a point when kinds of solutions are being entertained, I thought it was important for this body and probably other bodies to know that there are non-siloed, integrative, collaborative solutions that will solve the problem on multiple levels and not represent a Band-Aid for the problem.
Other questions? I have one. The program you're describing sounds really good, and I got the gist of it. I think I missed the beginning, which is how does this process of trying to stabilize someone in their home, how does it start? Is it one of your patients calling you, or is it a routine checks you do, or some other process?
So it's going to start with patient education. So we're going to be, we need to do a lot of education with our patients to help them understand the zone tool, to help them know where they are and what kind of help they need to get. So it could be a patient knowing that they need to have some type of intervention, you know, that they're declining, or it could be one of our nurses identifying that, you know, in a home visit or a phone call, but most of it would probably be the patient making a phone call into the nurse at the VNS office and the nurse doing a triage with the patient.
Thank you. Okay, last call for questions, comments about all of this. Well, I want to thank you both. It was really interesting. I mean, I have a lot of thoughts swirling in my head, and one is just a peek at the complexity of the healthcare system and the range of issues that people have that need attention. And so thank you for shining a little light on all of that and for helping us to become aware of some of the other components. You know, we mostly deal with the county stuff, the things that the county can do, but it's all connected and it's all part of our citizens' realities of what, you know, when they get sick or when they need help, they don't call the county. They look for whatever help they can get. So,
knowing that people have access to high quality, accessible care is like a societal responsibility. So we both agree in that. And again, not to create a liability for this body, but if from time to time, even on a regular basis, short updates like this make sense on focusing on one or a few topics, we're happy to do it. And this is just another avenue where we're able to talk about what our intentions and our progress involves, and feel free to invite us back.
thank you. I'd love to have you back in another amount of time.
It was very, very helpful and insightful. And for me, as a legislature, it's kind of like a big jigsaw puzzle. So occasionally bringing a piece in, I appreciate it. So,
Our pleasure.
All right.
Good day.
Thank you.
Thank you.
All right. Next up is the county administrator's report. We have Bridget here. Hello, Bridget.
Thank you, Dan. We have no report for today.
Okay. I guess we skipped that, actually. That was supposed to have been before. I notice other chairs, they check off each item as they do it, and that's why, but I haven't developed that habit, so maybe I should develop that habit. Okay, next up is the Department of Whole Health. We have Frank Krupa, the director of the department, and Frank, you have a resolution for us and a presentation, so in whatever order you would like to go.
Sure. Well, the resolution is pretty straightforward. It's just putting COVID funding on the books. It's remaining funds from a grant we received a year or so ago that we have until the end of the year to spend down. So there's been some expenses incurred, and we need to adjust the budget.
Thank you. Somebody want to move that? Travis moves, Randy seconds. Thank you. Just questions or comments? Okay, let's have a vote. Let's see, we have to do roll call. Randy?
yes.
Travis?
Yes.
Susan?
Yes.
And I'm a yes. That is unanimous. Okay, thank you. All right, Frank, back to you.
Sure, thanks, Dan. So the next thing up was a presentation about the concept of an academic health department and the project that we're working on. Wanted to kind of start with a little bit of context. Dan, you had actually talked with someone or got a hold of some bullets from a job ad from Cornell that was talking about partnerships between Cornell, Whole Health, and Cayuga Health Systems to try to improve health throughout the community. So it's a good time to be speaking right after hearing from Dr. Stallone. We've been talking with Cornell probably, I'm going to say pre-COVID. It's hard for me to remember how many years before pre-COVID. I just go pre-COVID and post-COVID these days. So pre-COVID, we were talking with Cornell when they started their MPH program about how we could strengthen our relationship. They're obviously a major provider of both future public health professionals as well as a lot of different research potential and opportunities that, quite honestly, we were not very good at accessing. So we've been having these conversations for several years. With Ithaca College, we've actually had a relationship going back even longer than that with our preparedness program. So our previous preparedness coordinator, Nina Saley, had set up a program with Ithaca College where she would go in and talk to some of their classes, and then she would bring interns from campus into the health department, where they would help her work on our preparedness planning. They'd learn about local health department. And then the second semester, she had a 2-semester program. The second semester, they would dig into whatever plan was due that year for the state, whether it be a pandemic plan, a mass fatality plan, a flu plan, whatever it might be. They really got hands-on practice there. And then they also worked with the Cornell team, with the Ithaca College team to set up their points of dispensing, so their flu pods. So the students actually ran those flu pods. We either provided nurses or we partnered with the health center on campus to provide nurses, but all the other positions were run by students. So it really created this opportunity for students to get hands-on experience. And we really wanted to build from that. So all of this kind of flurried into this idea of an academic health department post-COVID. As things were winding down with our relationships there, none of us wanted to lose the momentum that we had created by spending so much time together the previous couple of years. And so it felt like it was the appropriate time to dig into this concept and see if we could grow the formal relationship. We started with Cornell because they were very interested in having the conversation. As soon as I mentioned that we were doing this to the Board of Health, their immediate first question was, well, what about Ithaca College and TC3? So we really expanded the conversation to include all 3 higher education institutions. So that's a bit of the background. I'm gonna share, give me a second. I've got a few slides. Okay, you guys can see the slides?
Yes.
Good. So what is an academic health department? As I said, we're exploring this with the 3 higher eds. The Public Health Foundation describes an academic health department partnership as being formed by the formal affiliation of a health department and an academic institution that trains future health professionals. That is really the working definition. There's no rules, there's no regulations around this. It really is just the concept of making formal relationships between local health and a higher education institution. It's often compared to a teaching hospital. So if you're familiar with that concept, there's a lot of students that are learning as part of the work that's being done in those hospitals. So it's kind of the same way with the academic health department, where students are being engaged in the work of the health department, while at the same time there's research and other things happening to support both the health department, the university, college, and the local community. The idea here is to bring public health academia and practice together, right? Trying to break down those barriers between the learning of public health and its practice. What are some of the benefits of it for the community? There's additional resources, more people to do the work, competence is built, collaboration, that the government public health is informing what's happening in the academic program, so really helping to drive what the future public health professionals are learning in their education. And it has community engagement as core. For the local health department, it enhances our ability to do the work that we do with new support. It helps us recruit and retain staff because we're introducing new people to what we do, and hopefully they'll find an interest and want to continue on with us. More human resources available, continued education and capacity building services. It enhances our ability to assess readiness for accreditation, which is something that's probably on the horizon for us. And it can help us with our health assessments and our health improvement plans that we do every few years. What does the college and university get out of it? It expands the faculty expertise, and I'll talk a little bit about how we hope to do that. It enhances the educational experiences for students. It helps them with accreditation. It also helps with research, and we'll talk a bit more about that as well. And it gives them an opportunity to access other grants through collaboration. So what is it we hope to achieve with this? The first thing that we're working on is streamlining access to the departments for students seeking practical experience. So essentially internships. We've kind of had a haphazard approach where students would seek us out, or perhaps a professor would reach out saying, hey, I have this student that wants some experience, but it's not been really formalized. And so we're working on a formal application with guidelines about what it is we can offer, what skills we can expose people to, what different departments, programs are available for them from a learning perspective. So we really want to have a formal process so students can access that. They can tell us what they're interested in. We're sharing with them what we do and what we might have available. And it hopefully will make it a more streamlined process for making matches in our internship program. The other thing we hope to achieve is that it should create access for our staff to participate on campus in the learning environment as lecturers or even faculty, where they can bring their practical expertise into the classroom to help the students learn about public health, both from the global perspective and also with a very practical approach to it. So we think that benefits us in many ways. It gets us better public health professionals coming out of the higher education institutions. It's a staff development opportunity for our staff that might have an interest in sharing what they know and getting involved in higher education. So there's really multiple opportunities there for us to really be able to bring what we know into the classroom. On the flip side, there's also connectivity to local research opportunities for faculty. So as we all know, we have a world-renowned research institute in our backyard, but oftentimes our relationship hadn't been really well connected enough to be able to access opportunities with that research. So if you have a professor on campus that wants to do research on nutrition, for example, well, let's see if we can't match them up with our WIC program. Right? Or perhaps even another department outside of whole health that, might be useful. So we can be that conduit to make connections with the research. So not only does the faculty or professor get, a place to gather data and do their research, but we get the benefit of that research. So instead of them doing local health research in some other county or some other state, let's see if we can't make those connections here locally so we get the added benefit of the results of that research that can create local data for us or evidence-based practices right here in our community. So we're really hopeful that that linkage will help both the faculty as well as us as a community have access to their work. The formalized relationship, and this is really important, I think what we felt coming out of our dedicated time to COVID, this wouldn't rely on individual connections that can be short-lived, right? So obviously I know folks at Cornell. We've been working very closely for the last few years. If they or I were to leave, that relationship could dwindle, right? Because the people that had the direct connections are no longer here. What we're trying to build is a formal relationship that isn't contingent on any one person or individual, that there's a connection that's, memorialized in a memorandum of agreement or understanding that would allow this to continue beyond that. So that's what we're hoping to achieve kind of in a nutshell. There's 2 other health departments in New York that have done this. Monroe has done it with the University of Rochester, and the New York State Department of Health has done it with SUNY Albany. So we would be joining a short list of local health departments that have done this. There are many around the country that have done it as well. And if you want more information about that link there is to the Public Health Foundation description of academic health departments, as well as all of the self-identified academic health departments that exist around the country by state. So that's kind of it in a nutshell. We haven't signed any formal agreements. We're not there yet. We're in the very beginning stages of figuring out what this might look like. But we all feel like there is some good benefit in exploring this and ultimately getting there, both for the health department, for the students and faculty on campus, and the community at large. Yeah. So I'm happy to take any questions.
Thank you. Questions for Frank? Randy Brown.
Frank, looks like a great initiative. It could help everybody. Is there a cost to the county at all, or is it just staff collaboration?
No, there's no cost at all. And really, there is no cost really expected other than kind of the sharing of resources, as I just explained, whether it be a staff going to a class or participating in research that might be going on from campus, but or perhaps paid internships somewhere in the future. But those would all be things that would get developed over time, and obviously would go through normal budgetary processes to find out if resources were available. But at this point, it's really just the energy of the people that are involved in trying to make it a reality.
Other questions? I was going to ask, and you answered it right at the end there, where we are in this process, and you said we're at the very beginning. So I guess I would like to change my question to, what are some of the things that you imagine happening next, and in what kind of time frame are you imagining?
Sure. Well, right before this meeting, I was in a meeting with the internship coordinators from the 3 institutions to start to formalize our process for engaging with students, which is something we already do. It's a no-cost project, but it will improve the opportunity for folks to engage with us. So there's work like that that's already going on. The more formal process of moving towards an MOU, I think we're a little further off. I think we're still kind of managing through what that would look like. I think the higher ed institutions are looking at, how much they can bring to the table from a resource perspective. But I think generally speaking, those that are participating in the conversations are committed to continuing and growing our relationship so that way we can improve all of those access points that I mentioned.
Okay, thank you. Any other questions or comments? Frank, while we have you here, is there anything else you want to report from your department?
Well, I will say that we have next week on the 28th, we're hosting a town hall on suicide prevention. And so our local suicide prevention coalition's been working to put that together. It will be at GIAC in the evening. I believe it's at 5:30. And so we invite folks to come out. We have speakers from the healthcare system in our community to talk about how they play a role in intercepting suicide attempts, and what we can do as a community to do more for folks that are at risk.
Great, thank you. Randy has his hand up.
Yes, Frank, you and I have spoken a few times, maybe more than a few times, about mental health support in schools. And when we spoke last week, you mentioned that there were a few unfilled positions because just can't find the candidates. And you talked about some different ways you're looking at it to hire those people. And then you also mentioned that it's not a big cost to the county because I guess it must be a lot of it's billable. Could you elaborate on that a little bit?
Sure. So, one of our biggest challenges right now across the board is finding licensed professionals to employ. Being competitive in the marketplace is challenging with our salaries and benefit packages. So we have to be creative. We've done a few things. We've become a loan forgiveness site. So we applied to the federal government to be identified and credentialed as a loan deferment site. So folks that work for us for X amount of years get their loans forgiven, their school loans forgiven. So that's been a bonus. We've been able to shift our job description, which now allows us to hire individuals that are license pending, meaning they're in the process of getting their license in place, which was a challenge for us because before our job description said you had to be licensed. And people that graduate from school, it takes a few months. And generally, if they've interned someplace, they can go to that place and work differently, but can work as a social worker until their license comes through. We didn't have that opportunity for our many, many interns that come through our department. Now we're able to, so we're hopeful that's going to be a help for us. And with the governor's waiver of examinations for certain job titles, licensed clinical therapist is one of them. So for a year's time, you don't need to take an exam and you can get a permanent appointment. So these are all things that we're advertising to try and recruit more folks. It has helped. As I understand it, we're bringing on a few new folks here in the next couple of days, which hasn't happened in a while. So we're excited about that. To your question about expanding to the schools in 2023, the legislature did give us budget for two additional positions. Those were the ones that we were struggling to fill, but I believe we are going to be onboarding folks in a couple of weeks time so that we'll be able to get those up and operational. The reality is we could do more. The schools would want more. We could use more positions, but we just haven't been able to fill them. So having you all approve a bunch of positions that we can't fill really wasn't useful. So we're going to get these operational. We'll reevaluate where we are, and if there's a need for us to come ask for more, we'll certainly do that.
Thank you.
Any other questions or comments for Frank? All right, Frank, thank you very much.
Thank you all.
Next up is departmental updates. Let's see, how about we start with Ken Clark, Office of Human Rights. Good afternoon, Ken.
Good afternoon. My report is fairly short. As you may recall that in the spring, I announced that OHR and two Cornell departments were awarded a Cornell Just Futures Engagement Grant, and that grant was given to address racism, dispossession, and migration in the U.S. And in this fall, Richard Rivera from the Cornell Prison Education Program and I are convening with students for the second straight year related to these issues. Last year, students that were part of our cohort, about 5 of them, did research on 3 areas of the issues related to immigration, the efficacy of current U.S. practices, migration patterns, and the process of migration. So now this year's students are taking that research in order to plan programming. 3 programs during this year, the academic year 2023-24, that will address these issues. We're planning right now, or the students are planning, a program in late October, early November that will focus, on the efficacy of immigration practices. And then once they have secured the pieces in place for that program, they will be planning or laying the groundwork for 2 more programs in the spring, which Richard and I will convene on the other 2 topics. And we are looking at ways in which we do this not just simply as an academic exercise, but in ways in which we can engage a broader public, academic and community audiences, to contribute to the public discourse on migration and how, and address issues, ways in which immigrants' rights, human rights, have been violated by public policy. What are ways in which we can correct these issues? And so we're engaged in that area, and are going forward with our planning. So that is pretty much it for us. Everything else, I mean, is pretty much fairly routine. We are, seeing a pretty steady flow of contacts with the office related to a variety of issues, mostly as per usual, employment and housing issues in the main. So that's our report.
Thank you. Questions or comments for Ken? I have a question. The migration project you were just talking about, will that be focused mostly, and it is a national policy, is it mostly focused on sort of national, or is there a tie-in to migrants and immigrants in Tompkins County?
It will be really some of both. I mean, we'll be talking about issues that are happening nationally, but we also, too, are looking at ways in which we tie this into the reality of migrants here in Tompkins County. We are in process of exploring how we will do that, but we've had a long history of migration here, a long history of migrant workers in this community and in much of upstate New York. And so we do want to incorporate those perspectives in our programming, which may also come through persons who participate in the programs and who have expertise in working with migrants, and where possible, even the voices of migrants themselves.
Thanks. Yeah, I know for myself, it is a national issue, and it's usually framed as a national issue, and certainly there's parts of the country that are, heavily affected by it much more than we are. And when I meet someone here who's, recently come from another country and has ended up here, it always puts a different perspective on it for me. It's a little bit of a wake-up moment. Oh yeah, it's not something I read in the newspaper, it's here.
Yes, it is very much a reality here, and people are experiencing, and particularly, I mean, that impact on those persons who are undocumented. And so this is something that we do want to be able to provide some perspective on in a way that can be of benefit to the community.
That's great. Thank you.
Mm-hmm.
All right. Anything else for Ken? All right. Thank you very much.
You're welcome.
How about Kate Shanks Booth, County Youth Services?
Yes, good afternoon, everyone. How you doing? Not a whole lot to report here. I did send an email out to all the legislators this morning inviting you all to our municipal youth service event, which is going to be on October 12th, but apparently you may have a expanded budget and capital meeting for the budget in that evening, so we will miss you all, but I did want you to know we're thinking of you, and you're invited to that. So and you were invited to that. Obviously, you have to be at the other meeting, so we understand that. And I wanted to give the good news that we have our host homes through Family and Children's Services that provide respite for runaway and homeless youth. We have 2 families in Tompkins County that are going through the vetting process right now. This involves background checks, physicals, home inspections, and those sort of things to make sure they're ready for youth. And so hopefully those will be operational in the next few weeks. So that's been about a 2-year wait for us to get the licensure and operation certificate from the state. And it's going to fill a really important need in our community. So it's a really happy update that I wanted to share with you. So.
Great. Thank you, Kate. Questions or comments? All right. Well, thank you very much.
You got it.
How about Kit Kephart, Department of Social Services?
Hi, everybody. So we probably, like everybody, are focused on everything fall over here. We are beginning to really gear up for anticipated increases to our sheltering program. We have about 71 people sheltered right now, 57 adults, 14 children. But we know as the weather turns colder, we will begin to see increases to that. And currently, we have not had a cold night. Our code blue sheltering starts whenever the temperature drops down to 32 degrees with wind chill. So obviously that has not happened yet and hopefully won't for a while, but we are taking steps to be prepared to shelter people and be ready to help as that comes along. Similarly, we're gearing up for heat season, which doesn't officially start until November 1st, although there is work to be done to be ready for that and to kind of gear up for that. So we're in the process of working on that. We have many new staff, probably as everybody does. We've been very fortunate to be able to hire people, but we are definitely feeling the pinch right now of being really, really pleased to receive people, but also have a lot of people in training. And even though our numbers are better in terms of those working, we are going to still be in a very short space for a long time as people get up to speed and trained and able to handle cases independently. So it's a process, but that's where we're at. That's what we're working on these days.
Thank you. Questions or comments for Kit? All right. Thank you very much, Kit.
Thank you.
How about Lisa Monroe, County Office for the Aging?
Hi there. Hopefully you can see me.
Yes.
Hi.
It looks like it's sunny where you are.
I'm in the conference room, and our internet's a little unstable, so hopefully we stick here. But just a couple things. I did want to follow up on Randy's question, which was, do we have 2 home health aides? We have one currently at 21 hours a week, and we are hiring another one. Our program is a little different than Sue Ellen's. We serve people with our personal care aide that in our program, which is called ISEP, the Expanded In-Home Services for the Elderly program, which is not a Medicaid, Medicare program, so it's a different source of funding, but our paths cross a lot with VNS, so it was good to hear about their initiative. The other thing I wanted to say today is our fiscal coordinator, Bob Slocum. I don't know if many of you know him or have crossed his path over the years, but he's been our fiscal coordinator for quite some time now and worked for the county for over 30 years, but he'll be retiring at the end of the month. And we're having a little get together for him next Tuesday from 2 to 4. Everybody's welcome to come by and have some cake with Bob. But in the meantime, we've done interviewing and we've hired a new staff here, Rodney Main. Rodney has been with our office for over 14 years. Started out in fiscal and has done practically every other job in our office, which is great that he has the perspective that he does, but now he's our new fiscal coordinator. Started a couple weeks ago so he could shadow Bob before Bob completely leaves. So just wanted to welcome and introduce him.
Thank you, Lisa. Hi, everybody.
And that's all I got.
Welcome. Yeah, welcome, Rodney and Bob. 30 years, that's impressive.
Yeah, yeah, it is. He'll be missed.
Any other questions or comments for Lisa? Okay, Lisa, thank you very much.
Thank you.
Next up, J.R. Claiborne, Veteran Services. J.R., we're not hearing you. I do not see your mute button. I mean, I don't see that symbol, but we're not hearing you. Is your microphone on?
You can join us in the conference room, JR, if you'd like.
Okay, good. Thank you. All right. Well, if I had another department I would go to, but I think we've covered everybody.
Get him squared away here.
Okay.
Yes, you are on here. All right, can you hear me?
Yes, hello, thank you.
All right. Hello, everybody, one more time. Just my luck, I have all of my notes that just disappeared. Oh, here we go. All right, so yeah, thank you. I'm saying hopefully everybody saw got a chance to see my newsletter last week. Talked about some of the things that were happening. But a big thing for me is earlier this month, we started a new season for our Warrior Writers. So this is a twice-a-month session that we do here with our writers, our warriors, our veterans who come together and basically they write about things that have to do with their life, their time in service or whichever else, and really proves to be a cathartic moment for a lot of folks. Also, a few other things happening. This Friday was the POW-MIA Watchfire. A lot of people attended and my office helped support that along with the Team RWP. One of the things that I think is new since we last met is I started a new thing with Cornell Veteran Colleague Network Group. I was in their first show, so to speak, called VSO Insights. And this was something that was done virtual, where basically it was kind of a Q&A for those in the veterans community about veterans benefits. And then lastly, this month we also attended the Cornell Veterans Resources Fair, as well as the military and veterans reception they had up there. So just trying to make sure people know about our department and try to make some relationships up there.
Thank you, JR. Questions or comments? All right, well, thank you very much.
Thank you.
Next up for our agenda is minutes approval, minutes from the August 21st meeting. Is there somebody that would like to move that? Travis moves, Randy seconds. Any discussion? Okay, let us have a vote. Susan?
Yes.
Travis?
Yes.
Randy?
Yes.
And I'm a yes. That is unanimous. Thank you. Comments from committee members, liaison assignment reports. Does anybody have anything? Okay, the next meeting of this committee is on October 16th. And if there's no other business, then this meeting is adjourned. Thank you, everybody.